bringing together voices in child and youth healthcare. This is CAFC Presents.
CAFC would like to thank the following member organizations for their generous support of our knowledge translation activities: the IWK Health Centre, the Children's Health Foundation of London, the McMaster Children's Hospital Foundation, the Children's Hospital of Eastern Ontario, and the Children's Hospital Foundation of Manitoba. We would also like to thank the following Keystone partners for their ongoing contributions that support all of CAFC's programs and activities. All right, hello everyone, and welcome to today's episode of CAFC Presents. My name is Doug Maynard, and I'm the Associate Director at CAFC, the Canadian Association of Pediatric Health Centres. And welcome to today's webinar, which is titled Urgent Consult and Brief Intervention Clinic: Does it Increase Access and Reduce Wait Times? With all that out of the way, it's my pleasure to introduce our panel of presenters. With us first off, we have Dr. Nazreen Roberts. Dr. Roberts came to us from the United Kingdom in 1981 to the University of Ottawa, where she pioneered the urgent consult service for expedited risk assessment for children presenting to the emergency rooms. And since the year 2000, Dr. Roberts has been at Queen's University, where she's a full professor at the Faculty of Health Sciences in the Queen's University Department of Psychiatry, and she's also the chair and head of the Division of Child and Adolescent Psychiatry. Her main area of interest and research is child adolescent psychiatric emergency assessment and service provision and knowledge transfer. And joining Dr. Roberts, we have Nicholas Axis. Nicholas is a social worker who came to the Child and Adolescent Mental Health Urgent Consult Clinic at the Hotel Dieu Hospital in Kingston in 2012. Nicholas is a full-time social worker and therapist and is the team lead for the clinic, and he's been working with children and families for over 19 years. And joining them, we have Leanne Rapetti, who is a registered nurse who's been working in the child and adolescent area, as well as with adult inpatient psychiatric units at Kingston General Hospital and Hotel Dieu in Kingston. She joined the Child and Adolescent Mental Health Urgent Consult Clinic at the Hotel Dieu in 2012, and she's a full-time psychiatric nurse. So it is my pleasure to hand the virtual podium over to our team from Kingston to kick off the presentation. Over to you guys.
Thank you very much for that wonderful introduction, Doug, and good morning to all of you who are listening to this webinar. I'm going to start off by talking about the Urgent Consult Clinic and how it came into being, and the present Urgent Consult Clinic and how it stands. And I'm going to talk to you about whether urgent consults actually increase access and reduce wait times in our emergency rooms and our other ambulatory clinics. So we'll start off with, I'm sure you heard the national last night about self-harming kids and how there has been a grave increase in the number of kids and adolescents particularly presenting to the emergency rooms. So this can be emergency rooms that are general emergency rooms or emergency rooms connected to pediatric hospitals, in pediatric hospitals, or going to the pediatric department minor emergencies. So that's where a lot of the teams, self-harming teams, are showing up. And there's been a general consensus that the pediatric emergency rooms are getting overwhelmed by the mental health presentations in the face of absence of adequate resources. So in 2010 and 2011, I collected the data for emergency visits to our two hospitals in Kingston. One has a minor pediatric emergency room and a general adult emergency room, and the other is just a general adult emergency room. I kept data on that because I was running the inpatient unit and was having to see a lot of urgent consults. So I ended up by keeping data for that and then going to the LIN, which is our ministry, to ask for funding for a full-time urgent consult clinic. The rationale for that was that it would reduce the wait times in the emergency department, that we would provide rapid access to focus this assessment and intervention by specialized child and adolescent psychiatry staff. At our hospitals, if you go to the emergency room, you could get a first-year resident who is from family medicine, or you could get a first-year resident from psychiatry, neither having done much child psychiatry. The child psychiatry rotations for our trainees occur in the third year of their postgraduate year for psychiatry residents, and second year for the family medicine residents. So you needed to really provide access to some specialized assessment so that people wouldn't have to tell their story again and again. The other was to prevent unnecessary hospital admissions. Being in charge of the inpatient unit, I was aware of the number of times I would come in on a Monday morning where there would have been an admission that could have been avoided. So in the summer of 2012, the LIN actually funded a full-time urgent consult clinic, which was going to be myself, Nicholas, the social worker, and Leanne, the nurse, and it was going to be Monday to Friday. They agreed to fund it for a period of 24 months and said they would come back and review it and decide at that point whether or not they would give us full funding for permanence, which they did within 18 months of us starting. So what are some of the essentials of urgent consult clinic? Doug had said to you that this was something I had pioneered in Ottawa in the 80s. I had done that because of the pressure on inpatient beds, and also because my own training and personality lend themselves much more to emergency psychiatry across board. So what you need, I think, is somebody who's really interested in emergency psychiatry. And it's important to know that not everybody is interested in emergency psychiatry or urgent consults amongst the psychiatrists. The other is you need to have adequate resources and support from the hospital or whatever agency you're at, from the division, if there is a child division, your own division, the department, and the Ministry of Health. Fortunately, I've always had support from all of those myself. The other thing that is very important is because you're working in a high turnover assessment clinic, you really need to have a shared philosophy and a clear understanding of the goals and objectives of your clinic. Otherwise, it can easily become mired in delays. Thirdly or fourthly, you have to have time and willingness to provide basic adolescent mental health knowledge to ER doctors, pediatricians, primary care physicians, school boards, and community partners, because all those people access and send kids to the emergency room. When they turn up in their office or the school is concerned about self-harm, that's what happens. So it's very important that we provide education to them how to use the urgent consult clinic. A shared understanding in the community of what to use the urgent clinic for and how to use it is really imperative. Otherwise, you would just have another blocked clinic. So what did we do? I felt that it was very, very important that we did education for our community partners. So prior to this clinic even being funded, I had started with providing our community partners with ongoing education around mental health issues, common mental health problems presenting in the community, and how to deal with them. We then did a 2-day formal training session with our school boards and children's mental health agencies and talked about common mental disorders that lead to self-harm behaviors or crises, such as depression and suicide. This led to our developing a formal protocol which the children's mental health, the school boards, myself, the police, all were to sign publicly, saying that we would work together to ensure seamless delivery and seamless assessment and intervention for kids when they present a threat at the school or in the children's mental health agency. The other thing we did was to implement a mental health curriculum in the local high schools. We used Dan Kuchar's mental health curriculum for local high school kids. The curriculum is delivered to grade initially was delivered to grade 9 students. Now it's delivered to all the high school kids by their gym teachers. And it is to raise awareness. Sorry, we had a ping. It is to raise awareness of mental health issues, good mental health, issues around being aware when things are not changing for you or things are going wrong, trying to change attitudes, break down the stigma and the barriers to actually seeking mental health support when you need it. These are structured training modules, and they are available on the Teen Mental Health website of Dr. Kuchar, if anybody is interested in looking at them. So that was for the community partners. This is a threat assessment sheet that the school board fill out and fax it to our emergency room or to us in the urgent consult clinic when they're asking for an urgent referral. They rarely send the kids to the emergency room anymore, so they send them to us. And this covers a number of domains, as you can see. It looks at dangerousness, the supports that are present, and the ability for the child to accept help at the time. Then we did training for the primary care physicians, the ER docs, and the pediatricians. I have always worked very closely with these people for providing service on the inpatient unit as well as emergency response to them. So it was easier to get people on board for educational sessions around psychiatric emergencies in the emergency room or in your primary care or in a pediatrician's office and what to do with them. We then developed a formal training package that one of my colleagues, Dr. Khan, delivered to primary care networks in our region. And this is, again, an executive package that is available from Dr. Kuchar's site. And almost all of the people in our region have been trained on the primary care, in the primary care network, on how to assess common psychiatric problems in children and adolescents and how to manage them in the practice and when to ask for a psychiatric consult. In the hospitals, I've done repeatedly grand rounds and seminars for the emergency docs and with them, not just for them, but with them, where we have chosen cases and made presentations around those cases as to common psychiatric presentations, how to manage them, and what you need to refer and what you don't. We have ongoing dialogue with our physicians to provide services that are wrinkle-free. We work very, very closely with the pediatricians, and there is a lot of time that we spent learning together, and we had our first combined primary care continuing medical education workshop this year. So there's a lot of correspondence and talk between us. The advantage is that we are in a very small town. Kingston is a small town, so you can bump into people downstairs when you're going to get your coffee. You can talk to each other about the referrals they've made, or appropriate or inappropriate, and you can get a quick consult even on a telephone from one or the other. So what do we do when we're looking at the assessment piece? At the time of the registration to the urgent consult clinic, the kids all complete a brief questionnaire, which is for attention deficit disorder. Because there's a reason for this. A very large number of kids that present to the urgent consult clinic have either an existing diagnosis of this disorder or are diagnosed by us after. So this is the reason for choosing the attention deficit questionnaire. The other is a 6-item Kuchar Adolescent Depression Scale, which the adolescent fills out. And it is a screener for depression symptoms and suicidal, and asks a question about suicidality. Again, a good screen. The Strengths and Difficulties questionnaire, the adolescents fill out, and it gives you a good idea of what these kids are coming with. Then the staff, the student, the resident, or the Nicholas or Leanne will review the questionnaires, take a focused history from the youth and their parents, and they complete the tool for assessment of suicide risk. That's a clinician-completed questionnaire. Again, it's a good way of ensuring that we have covered every risk factor and everything that we know causes or confers high risk of self-harm or harm to others. And the psychiatrist, I meet with the staff, we clarify points with the youth and caregivers. I provide a diagnosis, present treatment options, including medication if necessary or other interventions. That's the TASER. I'm sure if this is not visible to you guys, you'll be able to, I'm sure we'll be able to have it sent to whoever needs it. Okay. So if you have questions about this piece or any piece of this organizational thing, feel free to ask me and I'll try and respond to them before Nicholas and Leanne present the 2 case vignettes. And then I'll follow up at the end by going over the results of our study on looking at how we managed in terms of whether our clinic is effective or not.
All right. Thank you, Dr. Roberts. And regarding those forms, if you're able to send those to us, we can certainly post those on the Knowledge Exchange Network on the same page where we will post the recordings and everything from this webinar, if we can do that. Or if they're available on the Kingston or the Hotel Dieu website, we can certainly link to them. Either way, we can make those available. And that's my chance. There haven't been any questions yet, but that's my chance to remind the audience to type in those questions into that question box. There have been a number of people who joined late and haven't had a chance to respond to the question that I asked at the beginning, which was how many people are watching with you. So if you haven't answered that question, just feel free to type that number into the question box, just so we know how many people are out there. Other than that, we'll, as I said, we'll type your questions in as you think of them, and we'll get to them at the next break in the presentation.
Hi there. I'm going to talk to you about case Vignette, a young girl named Heather that came into the consult clinic. She was referred by the local emergency department because of suicidal ideation. She had presented to the ER following an argument with her mother where she had stated she wanted to kill herself. Also, at the time of her assessment in the emerge department, she told the ER physician that she had been physically abused by her father for the last month, and her mother had not known about that abuse, and so the proper connections were made with CAS, which is Family Services. Heather gave a 2-month history of low mood and suicidal ideation. She had problems falling asleep and trouble concentrating at school. She had been cyberbullied for the last 2 years, and the bully had recently texted her to kill herself. Mother reported that while at home she was snappy, she would say things without thinking, and had episodes of anger where she would yell, swear, and actually throw things at her mother. Mother reported that she had an unplanned normal pregnancy and delivered Heather at age 36. She denied use of any drugs or alcohol. And Heather was temperamentally an easy baby and met all her milestones within normal limits. In grade 4, she was diagnosed with ADHD, and she is presently in grade 8 and has an IEP. Her mother has depression and takes Cipralex, and her father was diagnosed with ADHD, and he also had a history of alcohol abuse and incarceration due to theft and substance abuse. Both parents, they have been separated, since birth, and she's always lived with her mother. There was no other psychiatric contact other than seeing a community psychologist and a pediatrician who had tried her on psychostimulants at a younger age, but she did not like to take the medications. She presented to our clinic as a well-groomed 13-year-old girl, and her behavior was cooperative. Her speech was clear, coherent, and she made good eye contact. Her mood was described as sad, and her affect was euthymic and reactive. Her sleep showed initial insomnia. She had trouble falling asleep, probably worrying. She also discussed the text that she had gotten from some of her friends that she would think about that would cause her trouble. She had poor appetite, and her concentration was impaired. There's no evidence of social isolation, and there was no active suicidal ideation, death wishes, or plans. She had some anxiety, but no panic attack, fears, or phobias, and no avoidant behaviors. There is no evidence of thought disorder and no delusions or hallucinations. She was very fidgety, distractible, and showed poor frustration tolerance. She came across as average intellectually and had reasonable insight. And when we reviewed the Connors questionnaire, she presented as moderately severe in all domains. And in the 6-item Kuchar Adolescent Depression Scale, she scored a 2, and her low risk was in the TARS. She had a diagnosis given by Dr. Roberts, again, as ADHD. And we recommended counseling and medication. And we also referred them to connect with a local children's mental health agency for support. Potential benefits and side effects of the medication were explained to both mom and patient, and Heather was quite reluctant to restart a medication because of her past experience, and she did come back a few times, and we did a lot of discussion and some phone calls, and she did start taking the meds. And she was put on a trial of Concerta, 18 milligrams in the morning, and then we monitored her with weekly Connors questionnaires. The school was also contacted and made aware of the extent of the bullying Heather was experiencing so they could provide support. 4 weekly appointments were scheduled to review her symptoms. We repeated the Connors, as I said, and we reviewed medication effects and side effects. As there was significant improvement and no side effects, they agreed to continue the Concerta. Heather, at the end of the 4 weeks, was involved with the local children's mental health agency for distress tolerance group and was discharged back to her family physician, who then renewed the medication.
Hello. Sorry about that, little technical difficulties. So I want to start in on, this is Nicholas, by the way. Just wanted to talk about a case vignette that I had, which was John, who is a 17-year-old grade 12 student, who was brought to the ER with suicidal ideation. John gave us a history of 3 months of suicidal thoughts and had most recently been thinking of jumping off a local bridge as he was very hopeless about his future and had quite a low mood and feelings of anxiety. Constantly worried about his future, often worried about what peers thought of him, and getting overwhelmed with the fact that school was coming to an end. He was having problems with concentration and sleep, as well as self-harming behavior. And as we know, with a lot of times with girls that we see in our clinic, there's a lot of cutting, whereas with boys, they self-harm just as much, but usually with burning or punching themselves, which is what John was doing. His parents corroborated this and added that he was also withdrawn at home, spending a lot more time in his room, not enjoying the things he previously had. He was a planned pregnancy at age 29. There were no complications or substance abuse during the pregnancy. He was born at term with no complications, met his milestones early, and had no social or academic problems. There was no history of physical, sexual, or emotional abuse, bullying, or antisocial behavior. He did talk about occasionally using marijuana to help him relax. He denied any alcohol use, and he was not on any current medications or medical issues. And he was taking academic level courses at school and doing fairly well. He wasn't sexually active and didn't have a partner at the time. There is some family history of alcoholism with the maternal grandfather. There were anxiety and panic attacks in a maternal uncle, and a male maternal cousin was hospitalized for suicidal ideation and psychosis. On the paternal side of the family, a paternal grandmother had 2 nervous breakdowns and was on psychotropic medication. A paternal aunt had suicidal ideation with possible alcohol abuse, and a paternal uncle never finished secondary school and was incarcerated due to firearms and substance abuse. He had had no previous psychiatric or mental health involvement, so this is his first time experiencing any type of mental health intervention. And he presented as a quiet and shy 17-year-old male who looked his stated age. Good verbal expression, they were age appropriate, he was cooperative, he made good eye contact, speech was clear, coherent, and normal, but he talked very quietly and kind of softly, not really wanting to bother anyone with his problems. His mood was quite low, and his affect was dysphoric. He was, again, socially withdrawal, had insomnia with poor concentration. There was passive suicidal ideation, and he had a plan, but he was also future-oriented. He was looking forward to moving on and going to university. There is no evidence of delusions or hallucinations, obsessions or compulsions, or any disordered thoughts or content. There was evidence of anxiety and some perfectionistic traits, but no obsessive thoughts or compulsive rituals, and he had good insight, and his judgment was age-appropriate, and he came across as a young man with above-average intellect. So when he did the psychometric tools that we have, on the CAD-6, he scored a 15, and on the TASER, he was still at a low risk for suicide. And so our diagnosis for him at the time was adolescent adjustment disorder. And we talked about kind of what his strengths and weaknesses were going on. He had a very supportive family who alleviated some of his stress by letting him take the rest of the school year off, as he only had 3 credits left to complete. And this led John to feel a little bit better about the whole situation and said, you know what, I'm willing to do some brief intervention with the clinic for 4 weeks. So what I did is I sat down with him over the next 4 weeks and did some brief cognitive behavioral therapy. He noticed immediately an improvement in his sleep after practicing his breathing and relaxation techniques every night. He was able to identify his hot thoughts and practice his thought records weekly. He really took to the CBT quite quickly and found that it helped him to alleviate his anxiety. His suicidal thoughts were reduced to infrequent, and he felt like he was better able to manage them. His anxiety was reduced significantly, and as a result, he increased the hours at his part-time job. And he felt that he didn't need to have any further follow-up as he was functioning well, and stated that if he felt like he needed to, he could contact student health at university in the future if he felt like he needed some support. So before we go on to the next part, are there any questions for any of the vignettes?
Yeah, there were a couple questions that came in just as we were starting that second part of the presentation. People weren't typing quite fast enough to get them into that first question period. So these may be more relevant to Dr. Roberts' initial component. But the first question was asking, could you please elaborate on what constitutes an avoidable admission?
Yes, sure. So there'd be times I would come in and there would have been an admission of a child that had an explosive behavior episode, the parents bringing them into the emergency room and saying, I'm not going to take them home because we cannot manage them. This could be a child or it could be an adolescent. And the emergency room is usually, the on-call staff is usually adult psychiatry, the resident on call. And so the emergency team might decide, or the emergency doc might decide that the parents are refusing to take them home, this child is out of control, needs to be admitted. And I would come in on Monday morning, see the parents, see the kid, and would discharge them because they were not actually presenting with what I would consider high risk for self-harm or harm to others. So that's one example. The other example is what I would consider low intent, low lethality, self-harm behaviors that were admitted to hospital. So a good example would be a girl who is in a group home, has cut, group home brings her to the emergency room and says, we can't manage her in the group home because of her constant cutting behavior or her threats to harm herself. We won't take her back till she's had a proper psychiatric assessment. So that would be, those were some of the inappropriate admissions because they would then be admitted over the weekend or during after hours when we were not available. Since the arrival of the urgent consult clinic, those admissions have gone down because the emergency room actually has access. When a parent says, this child needs to be assessed or we've been told they have to be assessed, the emergency room doesn't have to say you need to go on that 6-month waiting list for outpatient assessment. And the alternative isn't just admit to the inpatient unit or a 6-month waiting list. The alternative of having an urgent consult appointment available in the emergency room for the emergency docs has meant that they will see the kid and say, you know, you've got an appointment tomorrow morning in the urgent consult clinic. Doing that allows most parents, it seems, to be able to contain themselves and their children for the night, or the group home to do that, which is much more frequent. The group homes are quite willing to take the kid back, have an awake 1-to-1, and come back to the urgent consult clinic next morning. So I follow the risk factors for completed suicide when I'm looking at what would be an inappropriate or appropriate admission. Does that answer your question?
Yeah, and anyone who asks a question, if you do have any follow-up, please do feel free to type it in, and we'll try and add that to the conversation as well, or if we didn't quite get your question. But the other question that came in was, Lana was asking, is psychiatry on site for the consultation, or are they remote?
So we are based in the hospital, in one hospital, and the other hospital is a 10-minute sprint across the park. So there are two hospitals with two emergency rooms. The pediatric emergency room, which is a walk-in and where most parents turn up with their kids under the age of 18 for whether mental health or non-mental health problems, is located on the first floor of the hospital that our clinic is located on. So we are co-located in the hospital, but we're not in the emergency room.
And the last question that's come in so far is from Gilles, and he is asking, what was the participation of the community physicians in your training seminars?
It was very good because we didn't call them to come in to have seminars. Dr. Khan and Dr. Julie Blair actually went to the primary care health networks in our region and did the training, it's a 5-hour training block. They did that with the family doctors on site in their practices. They participated very well.
All right. And that's all the questions we have for now. And Jeff did put a comment in. He's the person who asked the first question. He said that, yes, you did answer his question. That was great. And he thanks you. So we can over to you guys to continue on with the presentation.
All right. So I'm going to present to you. We've got more than 21 months of data. But when we put this together, that's what I had, was 21 months data for our urgent consult clinic. Because remember that we had to tell the ministry that we were going to meet certain benchmarks for them to fund us in the first place. And so they did. I mean, they made the clinic permanent, but we've kept our data because we need to be able to justify and to show that this is useful, especially in times of fiscal restraints when there are many things that are needed and competing demands. So here's what it looked like over the 21-month period. We had a total of 977 referrals, and we conducted 744 assessments. We find that the biggest bunch of kids, demographic that's important, is females, and grade 9 and 10 students, which seem to constitute a bulk of the referrals for crisis and for the urgent consult clinic. So 61% males, 39% females. A surprising finding was that almost half of the kids actually had in place some special educational adaptations at school. So that's for us, that's a very important issue. Like I said, the grade 9 and 10 students really almost constitute 50% of the 21-month referrals for assessment for crisis amongst the kids. And this graph is very interesting because if you look at the grade 12s, they really they constitute a very small percentage. And the graph goes up from grade 6 upwards and then descends down from grade 10. So trying to understand this, why grade 9 and 10, I think most of us know that the grade 9 year and 10 years are watershed years where there is a change in how you're being provided your education, what kind of commitments you have to make. There's a whole change in the social and academic expectation world of the kids in grade 9 and 10. And if you think of those kids with spec ed needs, it makes sense that a lot of them would really start blowing out of the water in grade 9 and 10 when the expectations become much more than what they can tolerate. The referral source, of course, we had provided our emergency docs with a book that has appointments in it. They can make those appointments at their discretion without asking us, and they will fill up those spots each night or each day, and we will have the referrals faxed to us with the question or the face sheet of the emergency visit for the next morning. So emergency doctors used 55% of the referrals came from them. We were very pleased to see that 27% of the referrals actually came from the family health teams and community physicians. And also, we had 1% internally, which is our pediatric and internal clinics. The school referrals are much less, as are the community mental health, because since I came to Kingston in 2000, I have done a lot of work with the school boards and the community mental health agencies for the appropriate use of emergency room and the urgent consult spots that I provided prior to the full-time urgent consult clinic. So this is really telling of how things are going in this community at the moment. So 53% of the kids were referred for suicidal ideation, mood, or attempt. And this could vary from just saying they were suicidal, having written an essay about being suicidal, actually having cut themselves, or having taken an overdose. So this was what the 53% was. 32% came for disruptive disorders. They tended to be the younger kids. 8% for anxiety, and 7% for other, which included psychosis and substance abuse. Okay. Substance abuse is a considerable problem amongst the kids that we assessed. So 57% of these kids actually admitted to using marijuana. Alcohol is 30%, and you can see the rest of it. So 35% of the entire population that we assessed reported substance use, and the most favored use of is the use of marijuana. These are important things because substance use really takes down your inhibitions. Having the lack of ability to think reasonably and stop, think, and plan is not there. If you're drunk or you're high and you have learning problems and you have impulse control problems, you tend to act out a lot more, either in self-harm or other ways. The other thing that we ask about, it's important for you to know that the assessment does not take 2 hours. The assessment usually takes about 45 minutes at best because it's very structured, and it's structured and focused in taking into account all the factors that we know contribute towards risk-taking behaviors or self-harm behaviors. So bullying and suicidality we know are connected to each other. We found that 45% of the youth reported some form of bullying amongst our kids. There was an association between gender of bullying. Females are bullied a lot more than boys are. There's also a significant association between history of bullying and suicidal ideations. Patients with bullying had 2 times higher rate of suicidal ideation compared to patients with no history. And cyberbullying is really the 21st century's a big nuisance that is gone on in a way that is really destructive. That causes a lot of difficulty for the kids, and kids who are cyberbullied have 3.6 times more suicidal ideation than those with a history of being verbally bullied. You know that the cyberbullying led to some very high-profile suicides that went on the internet that we know about. So what were the study variables that we looked at that were important? We looked at the fact that suicidal ideation was more common in girls. Being older and being female was significantly associated with presenting for suicidal or self-harm behaviors. Suicidal ideation itself was associated significantly with attention deficit disorder and major depressive disorder and adjustment disorder. One because of impulse control problems and the other because of lowering of the mood. We also found independent significant contributions for the absence of ADHD. So if you did not have ADHD and if you did not have ADHD, then it was served as a protective factor against feeling suicidal. Major depressive disorder is positively related with feeling suicidal, and anxiety disorder actually helps with not being associated with suicidality. If you think of the slide which showed reasons for referral, 53% of the kids were referred for suicidal ideation, query major mood disorder. If you look at the discharge diagnosis that we made after we had assessed them in the urgent consult clinic, what you see is that almost 50% of the kids had a neurodevelopmental diagnosis. So that includes attention deficit disorder with hyperactivity, it includes oppositional behaviors, it includes conduct problems, and it includes the autism spectrum disorders, all disorders that lead to or can be justified by virtue of some neurodevelopmental vulnerabilities, which of course come with learning disabilities and school difficulties. It was interesting that the number of people that were referred for anxiety was very small. There were 7% who were referred for anxiety, but when we actually did the assessments, we gave a diagnosis of an anxiety disorder to 31%. So I think that that's something that gets missed in a way. The other thing is depressive disorder was only 7%, and substance-related disorders were 4%. Other diagnoses that we gave were autism spectrum disorder or psychoses. What did we do with them after we saw them in the urgent consult clinic? 48% of the kids had 1 to 3 week follow-up with the urgent consult clinic because we have a brief intervention component with it. But 31%, which is a large number of kids, were actually sent back to the community mental health agencies or referred to the community mental health agencies for things like child management training for the parents, individual supportive counseling for the kids, or in our case, our community mental health agencies really provide some really good behavioral regulation and emotional regulation groups in there. And 15% had admission. This is an exaggerated number of kids. There was a reason for it. Some of these admissions were because I needed to have a psychometric assessment completed in them and a behavioral assessment completed to finish off the diagnosis and come up with recommendations. And the only way of getting a psychometric assessment was by admitting to the inpatient unit because they had a psychometrician available on staff. The urgent consult clinic, as you remember, has a nurse and a social worker and me. 6% were outpatient referrals. We have ambulatory clinics for mood and anxiety disorder, and for neurodevelopmental disorders, we referred very few kids to our clinic. So did the urgent consult clinic work? Absolutely. What it did was to take down emergency room presentations by 45%. These had previously been sent by primary care physicians, pediatric emergency, community mental health agencies, and the schools. There was a 35% reduction in weekend and after-hour emergency admissions. That is something that I have studied before. When you provide urgent access, the emergency rooms are able to manage the kids as well as the community is able to manage the kids better. Then there was an 11% reduction in inpatient admission despite us having admitted. 50% reduction, however, in the length of stay once the kids were admitted, because we were admitting them for a very short period of time. And some of the kids that were being admitted had already had some contact and were actually not needing to stay there as long as they needed to before. One of the most significant reductions was the referral to the mood and anxiety clinic. That was 31% reduction. The mood and anxiety clinic and the neurodevelopmental clinic have a huge referral rate. and at that point had waiting lists that were going into 6 to 8 months, which really is inexcusable and untenable. People cannot wait for 8 months for an appointment. And that leads to them turning up in the emergency rooms to try and bypass that waiting list. So there was a reduction of 31% in the mood and anxiety clinic referrals, and the referrals to the neurodevelopmental clinic have gone down subsequently a lot as well. That data I will present at another time. Then it's important to know that only 7.8% of the kids that were seen in the urgent consult went back to the emergency room for a subsequent mental health visit. So there was a significant improvement in triage by the emergency room, by all our community partners and physicians for the low-intensity, high-volume referrals. Low-intensity, high-volume referrals are the low-intent, low-lethality behaviors amongst the adolescents. Okay. We did a referral source survey, which was done as a survey monkey. So it was anonymous, and there was a 54% response rate. 87% of the respondents reported a reduction in child and adolescent patients in the emergency room and repeat presentations. 94% of the physicians and community partners felt that we had done very well. There were only 3% who felt that it was poor. The comments that we had asked for comments as well, was that it works great. They were really impressed that the urgent consult clinic was able to be available in a timely manner. They felt that we responded to their urgent need quickly, and that it was a really big add-on to the emergency room and psychiatric services. The ER docs really talked about how knowing the patient will be seen within 48 hours helps to reduce the admissions. That reassures them a lot. And the psychiatry residents doing call in our emergency rooms also felt that having access to urgent consults reduces their need to admit. So what were the lessons we learned? Very important is education. Education for the docs, education for the community mental health agencies, education for school boards, education for the public. So we hold public forums where we talk about what constitutes an emergency and how to deal with it, how to use the resources appropriately. And we also learned very quickly that some of our partners would learn the terminology and would bend the referral a bit and bypass the waiting list and send them to our clinic. We would then immediately, one of us would phone them and go over the fact that this child that they had sent was really neither at imminent risk or presenting crisis, that the problems were long-standing. So we actually had a chat about what else could you do instead of booking them in spots that should be used more frugally, if you like. We also found that the school personnel, by and large, abided by the parameters of the clinic, and they have an internal system, but there were some people who would actually ignore their internal protocols and direct parents to the emergency room. Again, we would find out who had suggested this, and then we would talk to the school board and allow the school board, our school board contacts to actually deal with that issue. One of the things that came out from our urgent consult clinic was that we felt very strongly that that 7% or 13% admission rate could be further lowered if we actually had access to a psychological associate or a psychologist and a behavior therapist. And the reason for that is the school boards are unable to provide and don't have the infrastructure to provide psychometric assessment to see which kids that are struggling actually have underlying cognitive vulnerabilities and limitations or have underlying learning disabilities that really are fueling the mental health issues that are being presented with. At this point in time, the jury is out. We are waiting with bated breath for our ministry to tell us whether or not they will fund for these additional resources. The other thing that has come out from the Urgent Consult Clinic that is very important, especially for pediatricians and pediatric centers and people dealing with pediatric crisis, is that there is a need for urgent consults from psychiatry for a proportion of the children under the age of 12 who need to be seen in an expedited, timely manner for their crises. These kids I have kept data on over the 3-month period to see if this was doable, really are kids who have significant and severe problems which make them difficult to manage in school, at home, in the community, and they come with multiple vulnerabilities for which there needs to be a concerted effort together with having all the basic assessments completed to put together a containment and treatment plan and management plan that will avoid them arriving in the pediatric emergencies and the parents saying, I'm not taking them home. So at this point in time, if we were to get the psychological associate and the behavior therapist to add to Leanne and Nicholas and I, then we will be extending the Urgent Consult Clinic down to kids from the ages of 5 up to the age of 12 instead of 13 and above. Thank you.
Are there any questions at the end of the presentation, in the last little bit, or throughout the presentation that anybody wants to ask? Now would be a good time.
All right. Well, thank you to all three of our presenters. That was a fantastic sort of example of one approach to this real issue of children with mental illness coming into presenting in our emergency rooms across the country. We did have one question came in, but as Nicholas said, please do start typing in your questions now, and we'll be happy to use the rest of the time that we have left available to us to answer any questions that you might have. The one question that did come in was just simply asking, what are the hours of the clinic? Is it open on weekends, extended hours, evenings?
No, the clinic runs Monday to Friday. So it is open from 8:30 to 4:30. Our community partners have been very, very good. So the Children's Mental Health Agencies, because we all work so closely together as a very cohesive community, have developed an after-hours walk-in clinic in areas of town that are easy to access, so that after hours, kids can go to the Children's Mental Health Agency walk-in crisis team. And that team, again, has direct access to our Urgent Consult Clinic by calling us the next morning for appointments.
And I think one thing I'd like to add is that a lot of times what happens is, for example, with our school partners, they might have a child at school who is talking about suicidal ideation or is exhibiting behaviors that are concerning. And a lot of times, rather than sending them down to the emergency room, what can happen is that the school board can have a conversation with the parent and say, look, can you keep your kids safe for tonight? Which many parents can do, and saying, if you can take them home and keep an eye on them tonight and keep them safe, I have an appointment for you tomorrow morning at 9:30 with the Urgent Consult Clinic. And for many parents, they can handle one night. They can handle saying, I can keep them safe tonight, I know I have an appointment in the morning, and that avoids them going to the emergency room altogether. So sometimes having that option really is helpful for the parents and avoids the whole process of going to emerge.
Could you, the next question has come in from Gilles, and he is asking, could you expand on the roles of the social worker and the nurse in the ER and the follow-up sessions?
So in the emergency room or the Urgent Consult Clinic, Gilles? I'm assuming in the role in the Urgent Consult Clinic. So I'll let each of them speak to what they actually do so that it'll clarify what their role is. Nicholas.
So for myself, as a social worker, I tend to have a lot more connections with the community. So many times it's about providing resources within the community or directing people to resources within the community. I've also been trained in different types of clinical therapies. So the biggest one we use here is CBT. So we will use cognitive behavioral therapy. We'll do brief 4-week interventions with them, teach them the basics, and then being able to connect them to other resources or providers in the area that can continue that work with them, but at least for that brief intervention. Also doing, as a team lead for the clinic, I also do a lot of coordination and consultation. So we have collaborative meetings every quarter with our community partners. That includes schools, children's mental health agencies, CAS, any other people that are involved to get feedback from them. What's working, what's not working? How can we improve the clinic? How can we improve our communication? We also do a lot of training. So many times I'll be doing presentations with school boards, with their new teachers or their behavior action teams. We deal with 3 different school boards in the region here. We have the Catholic School Board, the Public School Board, and then also, because of our geographic area, there's also, to the east of us, is Upper Canada School Board. So it's really about making sure that we're available to do those presentations, to do those trainings, and to be able to provide them with those services.
So talking from the nurse's point of view, in the clinic we do a focused history, which Nick and I both do, and then we do consult with Dr. Roberts, and after the recommendations are made, there's usually a brief follow-up, and so we'll do a med review and make sure there's no side effects, discuss any problems or concerns with the medications and make any adjustments with Dr. Roberts' consultation. And we also do CBT and brief sessions and discuss sleep hygiene, talk about other issues in regards to drug abuse, and also cyber safety. And nursing students have also been participating in the clinic that are with me during the week, and we've made a lot of these pamphlets that we can hand out that are resources for the families.
And that's certainly something that we can also provide to you, Doug, so that you can send an email version to staff people if they'd like of the brochures that we've created.
The brochures are important because they provide really pertinent information about sleep hygiene. Because the first thing for somebody who's having poor sleep is not to give them a sleeping pill or some kind of sleep aid. The first thing is to go over sleep hygiene. So Leanne got her nursing students with her to actually look at the sleep hygiene brochure. Nicholas developed something with them on cyberbullying, and we have a thing for parents and kids, a brochure for parents and kids on cutting behaviors, because these behaviors are so common that it helps for parents to understand and the kids to understand what they're doing for them. So I think if you want those, as Nicholas said, there's no problem with us sending it to you.
The neends question came in from Bobby Joe, and she's just asking, how many clients do you typically see in a given day?
Oh, dear Lord. It depends on how bad the day is going to be. So usually the emergency room has 4 spots. The emergency room has 2 spots. The community has 2 spots. However, so that means the morning is taken up by consult. So there could be 4. However, we could arrive to find that they have quietly booked 2 people for the same appointment because they were desperate, or that we have a message which is very urgent from someone. For example, pediatrics is calling from downstairs, then we will fit them in. So on a bad day, on a real bad day, we have seen 6 to 8 kids in the clinic on a day. But if you look at the numbers, there were 744 assessments completed for the 21-month period. That gives you a rough idea of how many kids we were seeing. Summers tend to be a quieter time for mental health referrals across my division, so in the ambulatory care clinics, in the inpatient unit, as well as the urgent consult clinic. So those July, August, when school's out, are really quieter months. But September to June are really, really busy. We can't say that we don't have enough work.
And then just to add on to that, so we have those 4 scheduled appointments per day, and those are in the morning, but that leaves the afternoons for Leanne and I to do a lot of follow-ups. So we talked about that brief intervention. If we're following kids for 4 weeks and we're giving them CBT or we're doing medication management, our afternoons are filled with 1-hour sessions or half-hour sessions to do that follow-up. And also, given the fact of how large our catchment area is, we're in southeastern Ontario, so we can go all the way from Prescott, which is near the Quebec border, all the way to Brighton, which is kind of merging into the GTA a little bit. We have kids that can be up to 3 to 4 hours away. So we do utilize at the Ontario Telemedicine Network a lot. So both Dr. Roberts, myself, and Leanne will do follow-up appointments through telemedicine so we can see them on secure video chat. We'll do follow-ups by phone. We like to have them come into the office to see them directly. But, you know, when you're 3 hours away in Bancroft, and like today where it's snowing outside, it's not really prudent or fiscally able for the parents to afford the gas to come down to Kingston and see them. So we try and utilize all the services and resources that we have to get in touch with our kids.
I find that the Telelink is really an amazing development because it has become better and better over the last 10 years. And having the capacity to be able to do assessment as well as to do follow-ups on the Telelink saves a lot of time for the families, but it also provides us the ability to actually do a lot more work. When Nicholas and Leanne are doing follow-ups, I will see the additional kids that have come through. I also provide 3 urgent consults at this point without additional resources for the under 12 urgents to our COPC. So our children's outpatients and the pediatric emergency room have their own 2 to 3 spots that they can use. That would be just me seeing a patient by myself.
The next question is coming in from Jeff, and he's asking, have you done any analysis of the economics of the clinic? You did present a slide with the sort of the outcomes as far as reduced admissions and that sort of thing, but he's going on to ask, do the cost savings outweigh the costs associated with the program specifically, or have you done that specific economic analysis?
I haven't, but I can assure you the funders have. I think that both the hospital finance department and the hospital senior leadership, as well as the LIN, would be the people to answer that question because they would have exact data for it. They would not entertain any requests for further funding from me and us if they were not seeing that we were making a difference fiscally, because we know what's coming down financially through the health system. So I think that that's a question they'd be able to answer. I haven't kept that data, but I'm sure that we can find it out.
All right. And David is asking if the brochures that you mentioned can be posted for review by the participants of this webinar. You know, again, either through a link to your website that we have up on the screen now, if they're up there, or if you can send those to us and we can post them on our Knowledge Exchange network.
Yeah, I have the brochures. I have them in an electronic format as well, so they're much easier to be able to just email out and be able to hand out to clients. So that's something that I can provide to you, Doug. There's 3 brochures, one on cyber safety, one on cutting, and one on sleep hygiene. We're also in the process of developing 2 more, one on drugs and alcohol, and the other one on mental wellness and kind of mental wellness behaviors and things parents can do with their kids. So I can definitely send those to you, as well as those earlier in the session when we were talking about the psychometric forms we use, like the CAT-6 and the TASER-A. I can provide those as well. All
right, that'll be fantastic. We had a number of questions asking for those, so I'm sure that will be greatly appreciated. So that actually is the end of the questions that have come in so far. So we'll just a sort of a last call we'll put out there for any last questions that people might have. We'll get you to start quickly typing those in if we can. And
I'd like to make a comment.
Sure, absolutely.
And that is that the questionnaires are not diagnostic, but it would help you if you were confronted with a kid. If you did those 3 questionnaires with them, it doesn't take very long. The brief Connors questionnaire is 10 items. The CADS is 6 items. And your clinical thing is, whilst you're taking the information from the patient, it just reminds you what are the important things to ask about so you don't miss something. They will actually help you to focus. If you get the patients to complete it while they're waiting, and it cuts down on the time you need to spend with them, but also it will direct you as to which patient to send where. I think that they are good screening questionnaires to have. If you have your own, that's fine too, but it really helps to have something that can guide how you're going to triage.
And with that, perhaps we have not had any more questions come in, so I think maybe we'll just take this opportunity to perhaps wrap it up, and we'll hand it back over to the team in Kingston for any final comments that you'd like to close off this presentation with.
Well, I'll tell you something good that's happening for us is that since the Urgent Consult Clinic started working full-time as a clinic, we have had the donations of a 6-year-old child for our Urgent Consult Clinic of his pocket money, which was $46, I think. And then that has led to some other funding sources actually looking at possibly funding the Urgent Consult Clinic. We cannot use that funding for staffing, but it certainly helps with many other things. So I think that the community itself and our community and region itself appreciates the rapid access that they have and the timely rapid access, and the fact that they know it takes away their sense of urgency and immediacy as well, and helps them to feel less stressed about or less worried about the kids that they are confronted with.
I think the one thing I'd like to add is, again, thank you to everybody for participating and attending the webinar today. Just for those of you that are curious, we were so close to the 24-month mark, how did the numbers turn out? Just to let you know that over the 2 years that we've been active, we saw 805 patients. So in every year, we've done about 400 assessments. So, and that continued in our second year, and I think so far in our third year, it's also continuing to kind of track that way. So the more and more that we do, the more and more we streamline and kind of focus. And the waiting list now for the other clinics, both the mood and anxiety clinic, the neurodevelopmental clinic, are now down to a 6-week waiting period, which I think at our peak was about 6 months to a year. So I think the fact that we've gotten it down now to 6 weeks in the other clinics is also helpful to show that the kind of impact that we're having with child and adolescent mental health here at Hotel Dieu.
All right. And Leanne, any final comment from you?
Having us. It was a pleasure to talk to you guys about our clinic, and we love our job, and we hope that other people can maybe replicate our clinic.
All right. Well, that's fantastic. And this whole topic of sort of children with mental illness presenting at emergency rooms across the country, as I mentioned at the beginning, is such a huge issue for any time we go across the country and speak with our members, the members at CAPC. That's always an issue that comes up. We had a session at our annual CAPC conference in October, just a few weeks ago in Calgary, on what was called the crisis of mental illness in the emergency rooms of our children's hospitals. We're also in the process of planning another presentation to bring 2 other programs from our children's hospitals and what they are doing to try and engage community services and the children's hospital in addressing this issue from our colleagues at the IWK Health Center in Nova Scotia and at the Saskatoon Health Region in Saskatoon. So we don't have a date for that one coming up, but do stay tuned. And if you are interested again in this topic or any of our other webinars, you can always go to our CAPC Presents page on our website at cafc.org/CAPC Presents, and you can sign up to receive the notifications, and you'll be able to register for that webinar. And with that, I think we will wrap it up. Thanks again to our presenters. Really a great presentation and really timely and relevant, as I said, to this community. So a huge thank you to you for a great presentation, and to our audience for joining us. We always do these presentations at 11 a.m. Eastern Time on Wednesdays. We are off next week week, but the following week, December 3rd, we will be back with a presentation from CAFC's Interfacility Critical Care Transport group, talking about Ebola in the interfacility critical care transport environment. It will have a lot of content focused on those folks that do neonatal and pediatric transport, but we will be talking about Ebola more broadly in the context of the child and youth healthcare sector. So please don't hesitate to join us for that one if you are interested in that topic. And then that will wrap it up for before Christmas, before we're back with a full schedule throughout January and February. So thanks again to everyone for coming, and we hopefully will see you next time. Bye, everyone.